Imagine sitting down to your favourite meal. The food is familiar, the setting is familiar, but your brain no longer quite understands what to do. You might forget to chew, hold food in your mouth without realising, or lose track of the conversation and the plate in front of you. For people living with dementia, eating and drinking can slowly shift from something automatic and enjoyable to something confusing, risky and exhausting. When that happens, swallowing problems are not just about the muscles in the throat, they're also about attention, memory, sensory changes at the table. In this video, I'm going to explore what that looks like. Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In this video, I'll give you a quick overview of what dementia is, then talk about what dysphagia or mealtime difficulties looks like in someone with dementia. Dementia is an umbrella term for a group of neurological conditions which cause progressive decline in cognitive abilities, such as memory, language, problem solving and visuospatial skills. This cognitive decline has to be significant enough that it interferes with someone's daily life for dementia to be diagnosed. There are lots of different types of dementia depending upon the underlying mechanisms and which parts of the brain are damaged, and this leads to the different symptoms that you see. So examples of dementia include Alzheimer's, vascular dementia and Lewy bodies dementia. But the one thing that connects them all is the fact that there's a progressive decline in function that eventually leads to death. Now we have a rough idea what dementia is. Let's talk about what dysphagia or difficulty swallowing and mealtime difficulties actually look like in someone with dementia. I explained in another video that speech and language therapists often break swallowing down into different stages named after the part of the body where they are happening. Dysphagia can occur at any one of these stages or across several of them all at once. You will have noticed that I also use the term mealtime difficulties. This is a term that is used by some healthcare professionals and researchers to describe a certain set of behaviours that make it difficult for people with dementia to eat or, more frequently, to be fed by others such as their family members or members of nursing staff. Now I'm going to be honest with you and say that I'm not keen on this terminology. It's often used to make it look like these behaviours are somehow different or separate from real dysphagia. In practice though, this can lead to referrals to speech and language therapy being rejected, limited or inappropriate support from services, or the impression that these difficulties are not even part of a speech and language therapist's role. I strongly disagree with all of this. All of the behaviours grouped under the mealtime difficulties also occur in other conditions where people have dysphagia, such as learning disabilities, mental health and traumatic brain injury, so I see little value in distinguishing between the two and using separate terms. Going forward then, I will just describe everything under the umbrella of eating, drinking and swallowing difficulties, dysphagia, and highlight the underlying mechanisms for the signs and symptoms people see at different stages of the swallow. In the pre-oral phase, someone usually anticipates and prepares for food and drink entering their mouth by looking at it and starting to secrete more saliva to help break down food in their mouth. It also includes the person physically moving the food or drink to their mouth as well. Someone with dementia can have lots of difficulties in this pre-oral phase, so I'll group them into broad areas to make them easier to understand, though I do acknowledge that there is some overlap between some of these areas. To begin with, you have to be awake and able to orientate yourself to the food and drink first, which is challenging if you have difficulties with arousal and attention. People with Lewy body dementia or Parkinson's disease dementia often have fluctuations in their alertness and attention. They can appear drowsy and switched off at times. This makes it difficult for them to notice it is mealtime or stay engaged with eating and drinking. People with vascular dementia can often have difficulty sustaining concentration for a whole meal and may be easily distracted whilst eating and drinking. As all dementias progress to moderate and severe stages, arousal and attention become a problem for everyone. It becomes more difficult to rouse people and they may fall asleep during meal times. When they are awake, they might struggle to attend to the fact it's a meal time, stay at the table and keep going with eating and drinking without getting distracted. Many people need frequent or constant prompting from caregivers to initiate eating at all. If someone is awake and orientated, the next consideration is appetite and motivation. Does the person notice hunger and are they motivated to eat and drink? People with Alzheimer's often show decreased appetite. They often express less interest in food than they used to, even to their old favourite foods and drinks. They might have smaller portions or give up halfway through meals unless encouraged by someone else. People with behavioural-variant frontotemporal dementia or semantic dementia show the complete opposite pattern. Because the frontal lobe of their brain, which usually regulates things like their impulse control and reward systems, is damaged, they often develop an increased appetite or seek out certain foods, such as things which taste sweet or are highly flavoured. You might notice they crave certain kinds of food and eat very quickly. They might even raid cupboards to get access to these foods, which can be challenging if they live in a setting with other people, such as a care home. As all dementias progress to moderate and severe stages, people have decreased appetite and say they don't feel hungry. They might stop recognising signs of hunger completely. When they do eat, they often say they are full after a few bites and often gain less or no pleasure from eating the small amounts of food they do manage. Eating often becomes more about fuel and nutrition rather than enjoyment. Closely linked to appetite and motivation is broader perceptual and visuospatial skills. Can someone perceive, recognise and find their utensils and food in space? People with Lewy bodies dementia and Parkinson's disease dementia especially can sometimes experience visual, auditory, olfactory, tactile and gustatory hallucinations. So they see, hear, smell, feel and taste things that are not real. Hallucinations can be extremely distressing to the person and disruptive to the whole eating and drinking process itself. Imagine sitting down to eat and hearing voices talk about you. You constantly smell something burning like something is on fire. You feel like something is crawling over your skin. Or when you do manage to have something to eat, you have a metallic taste in your mouth. If someone does perceive their utensils and food in space, they can have something called visual agnosia, which means despite their eyes working correctly, they cannot recognise the objects in front of them. They might stare straight at a plate and not recognise the objects on it as food they can eat. Wendy Mitchell, in her book What I Wish People Knew About Dementia, gives a really vivid example of sensory difficulties when she describes being confused by a black tablecloth. It left her confused about whether the table was covered in a giant sinkhole in the middle of the dining room. Once her eyes had adjusted and her brain had caught up, she realised it was indeed a tablecloth. She had no idea where the table started or ended underneath it. She talked about how certain foods on a white plate would be invisible to her. At times her cutlery would chase the food around the plate until it fell unceremoniously off the edge, and once it wasn't there to see, it was like it simply never existed in the first place. If the person is able to feed themselves, they might misjudge where their mouth is relative to the cup or utensil, leading to repeated missing or food landing against their lips or chin. Sometimes their senses become heightened. Someone with hyperacusis perceives everyday noises and sounds as excessively loud, uncomfortable, and even painful. So you can imagine the everyday sounds at a table, the small talk, the sound of liquid being poured into a glass, the scrape of a knife against a plate whilst cutting food up, etc., can cause someone pain. The next step after recognising your food or drink is being able to move towards it, grabbing your cutlery, using it, and transporting the food or drink to your mouth. People with Alzheimer's disease and frontotemporal dementias can often experience difficulty planning and organising these movements, which we call apraxia. That means when they try to complete a voluntary movement with their arms and hands, they struggle to get started or put the steps in the right order. They may stare at utensils and not know how to pick them up, move the fork or spoon and get stuck mid-movement about what to do next, bring the knife to their mouth instead of the fork, or grab food with their hands and eat very messily, even though they've used cutlery previously without any problems. In these cases, the physical strength of the muscles is not the problem, it is the planning and sequencing of the actions. But people with certain kinds of dementia, such as Parkinson's disease dementia, Lewy bodies dementia, and vascular dementia, can also experience physical weakness and movement disorders, which can make it more difficult to eat and drink. Their posture can become stooped or unstable. It can also affect specific parts of the body, such as the head, the neck, arms, and hands, which may not move as freely as before. Muscles can become stiff and difficult to use. In some cases, contractures can develop where joints become fixed in awkward positions, so the person may no longer be able to hold cutlery at all. In other cases, the muscle is strong, but they are affected by a tremor. This might be a regular rhythmic shake, or a more jerky involuntary movement that are more like a spasm. All of this makes it much easier to drop cutlery, spill drinks, struggle to cut food up, and can mean it takes a long time to self-feed and is very tiring. As all dementias progress to moderate and severe stages, many people with dementia have such marked difficulties with apraxia, posture, and physical weakness that they can no longer feed themselves, even if they wanted to and are willing to eat. In these cases, they become dependent on carers for hand-over-hand feeding or feeding them directly. If the person with dementia is able to physically move the cutlery themselves, they need executive functioning skills to decide how much food to load onto their cutlery, how quickly to put the food into their mouth, when to pause, and whether to alternate between eating and taking a drink. This is about control and judgment, not basic movement. People with Alzheimer's disease often have executive function difficulties. They struggle to decide what to eat next and will often sit holding the fork without taking a bite. They might take small mouthfuls, and there may be long pauses in between mouthfuls. Someone with behavioural-variant frontotemporal dementia does the complete opposite. They might take very large mouthfuls and shovel food into their mouth really quickly without even chewing, or before they've even swallowed their previous mouthful. They might cough or struggle but persist with what they are eating and drinking and not alternate. For example, if they struggled with some food, they might not stop and take a sip to help clear their throat. They just keep eating more and more food. Once a person is eating and drinking, you also need memory skills to stay on task and remember that you're in the middle of a meal and to keep going rather than walking away after a couple of mouthfuls. People with Alzheimer's disease have prominent memory difficulties. They may forget that there is a meal in front of them, forget that they already started eating, and lose track of what they are doing altogether if something distracts them due to their attentional difficulties discussed before. This means they might just stand up and leave the table, even if they've only managed a few bites. Often they cannot remember if they have even eaten at all or how much. These memory difficulties can cause physical damage. Someone with dementia might present with scald marks on the inside of their mouth because they forget between mouthfuls that they've eaten something that is too hot for their mouth and do it again and again. As all dementias progress to moderate and severe stages, memory problems are usually present for everyone regardless of dementia type. People might forget they've just taken a bite. They might not recognise who is trying to help them eat or drink. They generally require almost constant prompting to stay on task or maybe need to be fed by someone else. Finally, we have behavioural and emotional regulation. Even if someone is awake, is hungry, can see their food and is physically able to move it to their mouth, they may still need help to cope with the environment and accept help from carers to stay at the table and eat. People with behavioural-variant frontotemporal dementia often experience significant changes in behaviour and emotion. They may become disinhibited or impulsive, such as saying or doing things that are out of character, or socially inappropriate, such as swearing. They may grab food from other people's plates. They may become agitated if their routine is changed and show limited insight by refusing offers of help when it is clearly needed. People with other kinds of dementias can also become suspicious about the food they are being given and maybe become very distressed. They might shout at people, throw their food or hit out at people if they feel like they are being forced to eat. As all dementias progress to moderate and severe stages, people have little reserve for coping with stress or change. A sudden noise, a different cup, a new carer will cause distress, and they may refuse to eat anything in that situation. Now for the oral stage, which is named after the oral cavity or your mouth. Here is where people chew food up into a consistency that can be swallowed, called a bolus. The same cognitive signs that we saw in the pre-oral stage can also affect the oral stage of the swallow. If someone has difficulty with arousal or attention, they might drift off or stop chewing when food is still in their mouth. When prompted to restart, they might just continually chew the food in their mouth without swallowing and may need you to prompt them to swallow. Drool may escape their lips. If you ask them to open their mouth, the food might just be sat on the top of their tongue or sometimes pocketed in the lateral sulci, which is the space between the teeth and the cheek. Once food is in the mouth, reduced appetite and motivation mean the person with dementia actively spits the food out, lets it fall out the front of their mouth, or puts little effort into chewing and it just sits in their mouth instead. In frontotemporal dementia, I suggested a different pattern of behaviour compared to more common dementias. Here the person has quickly crammed food into their mouth in the pre-oral stage. The size of mouthfuls is often too large and you notice in the minimal mastication or very fast chewing. The boluses are therefore less well prepared before they are transported to the back of the mouth for swallowing. If the person has perceptual or visuospatial difficulties, they may misperceive or fail to recognise what is in their mouth, such as an unfamiliar texture, and spit it out if they deem it unsafe or hold it in their mouth. Related to sensation is the finding that people with Alzheimer's disease have been found to produce less saliva than others. You need adequate amounts of saliva to lubricate the structures in the mouth and for chewing. This hyposalivation is thought to underpin some of the difficulties people with Alzheimer's have been observed to have with oral sensation, specifically taste and texture perception. If you do not have enough saliva, it makes it more difficult to eat certain textures of food, which might also explain changes in diet or refusal to eat certain textures. Another unintended consequence of producing less saliva is that the concentration of oral bacteria in saliva increases significantly, so anything that they do aspirate into the lungs is more likely to increase their chances of catching a chest infection. Those with apraxia or motor difficulties have difficulty coordinating their lips, tongue and jaw, so they may be unable to open their mouth at all, which may be perceived as refusing food by their carers. They might be able to open their mouth but lack control, so drool escapes or food and drink fall out of their mouth. People sometimes struggle to form a cohesive bolus as the tongue and jaw move slowly, so chewing is inefficient. They also struggle to propel the bolus to the back of their mouth, and residue may be left over on the tongue or in the lateral sulci. People with Alzheimer's, for some reason, seem to struggle more with fluids compared to those with vascular dementia, who appear to struggle more with boluses containing food or diet. Executive function difficulties in the oral stage don't usually create new signs and symptoms. They change how much and how fast food goes into the mouth and how long it stays there. In most common dementias, slow intake and long pauses mean small amounts of food remain in the mouth until you prompt the person to swallow. With frontotemporal dementias, you often see the opposite pattern. People eat quickly and put overly large boluses into their mouth. Because their executive function is reduced, they do not stop themselves doing this, so there are large bites, fast chewing and cramming, and this means the oral cavity is often full. The boluses that are propelled to the back of the mouth, again, are often not chewed properly. People with memory difficulties often forget there is food in their mouth. They may stop and wander off mid-mouthful, or, if they are being prompted, you may see the same pattern described above with attentional difficulties. There is that continual chewing and mouth-holding without swallowing characteristic of dementia. Finally, behavioural and emotional regulation difficulties might result in issues like someone spitting their food out deliberately, or talking with food in their mouth, so it escapes out the front of their mouth, or moves backwards prematurely, becoming a choking risk. Up to this point, we've discussed the pre-oral and oral stages of swallowing, which are under the conscious or volitional control of the person themselves. That is where all of the cognitive skills we talked about, such as attention, memory, and executive function, really influence swallowing and, unfortunately, explain why people with dementia struggle so much, as they have difficulties with all of these areas. The pharyngeal stage is different though. This is named after the pharynx, and it is where the bolus is propelled through the throat while the airway is being protected. Once the bolus reaches the back of the tongue and the swallow reflex is triggered, most of this action is automatic and happens without you having to think about it at all. In the pharyngeal stage, people with dementia commonly present with three types of difficulty. The first type is delayed initiation of their swallow. This means more of the bolus enters the oropharynx or their throat before swallow is triggered, which increases the risk of food and drink being aspirated into the lungs, especially thin fluids. There is evidence that this delayed initiation starts early in Alzheimer's and gets worse as the condition progresses. People with frontotemporal dementia also seem particularly prone to increased food leakage into the pharynx before swallow is triggered. The second type of difficulty is reduced airway protection. In a typical swallow, the larynx or voice box closes, then moves up and forward, with the epiglottis tipping over to protect the entrance to the airway. People with dementia show incomplete laryngeal closure, reduced higher laryngeal movement, and impaired inversion of the epiglottis. This means that the airway is left open more than it should, and there's a much greater chance of food and drink entering the airway than normal. There is also evidence that this incomplete laryngeal closure starts early in Alzheimer's and vascular dementia, but won't necessarily be obvious in a bedside assessment to begin with. But as mentioned above, it gets steadily worse as the condition progresses. In Parkinson's disease dementia, bradykinesia and muscle rigidity affect laryngeal elevation and timing, so reduced airway protection is common across several subtypes of dementia. The final type of difficulty is poor pharyngeal clearance. In a typical swallow, the bolus is propelled through the pharynx by rhythmic contractions of muscle called peristalsis, through the upper esophageal sphincter and down into the esophagus. People with dementia show poor pharyngeal clearance. After they have swallowed, there is often residue of the bolus left over in parts of the pharynx called the valleculae and piriform sinuses, and some of this then tips over into the now unprotected airway and aspirates into the lungs. there is evidence that these difficulties are common in frontotemporal dementia, but also occur in others, such as Alzheimer's as well. The final stage of swallowing is the esophageal stage, named after the esophagus, where the bolus travels down the esophagus and into the stomach. Most of the research in dementia has focused on the mouth and throat, so we know much less about how dementia affects the esophageal movement. In older people with dementia, esophageal problems such as reflux or slower clearance are usually related to aging or other medical conditions rather than dementia itself. So any symptoms of food sticking lower down or regurgitation should be discussed with the medical team. So those were some of the common signs and symptoms of dysphagia in dementia, but that list was by no means exhaustive. It's becoming clearer that each subtype of dementia has its own distinct profile of dysphagia, which makes sense given the different underlying pathologies. Dysphagia in Alzheimer's disease appears to be driven largely by changes in the sensory and timing aspects of swallowing, while vascular dementia tends to have more of a motor pattern. People with frontotemporal dementia often show more of a behavioural or emotional profile around eating and drinking, such as changes in appetite, food preference and mealtime behaviour. Those with Lewy body dementia and Parkinson's disease dementia typically show a Parkinsonian dysphagia pattern with clear difficulties in the pharyngeal stage and a higher risk of food or drink entering the airway. On top of this, people in these groups can be very susceptible to hallucinations and fluctuations because of the medications they take, which can further affect alertness, safety and mealtime participation. Dysphagia presentations in all of these dementias change over time as the condition progresses from mild to moderate to severe, and are further complicated by other medical comorbidities and the side effects of other medications, which means working with people with dementia can be extremely challenging but also very rewarding. It's also worth mentioning that I've focused mainly here on what happens inside the mouth and throat, but the social side of mealtimes also changes in dementia. Things like feeling overwhelmed in busy dining rooms or losing confidence eating in front of others. And these can have a big impact on how much people actually eat and drink too. It's clear that more research is needed to fully understand all of these different factors to guide speech and language therapy practice going forward. So that's an overview of what dementia is and how dysphagia presents in someone with dementia. If you found this video useful, make sure you like it and subscribe to the channel. If you want to find out a bit more about how you can help someone with dementia who has dysphagia, including the mealtime environment and social support, then look out for a future video. In the meantime, maybe check out one of the other videos on the channel. Otherwise, thanks for watching and take care.